Hear you on 8. You on 8. Okay, you're clear. Stand by for your base.
This is Loud and Clear EMS Guiding Principles. I am your host, Will Berry. I'm a practicing flight paramedic in North Carolina, and I'm joined by my co-host, Ross Orpit, a practicing emergency medicine physician and EMS medical director in Southwest Colorado.
And I'm super excited to introduce our guest today, Will. Our guest is Greg Doctor, who is a wilderness medicine specialist. He's fellowship trained in wilderness medicine and is a coworker of mine here in the mountains of Southern Colorado. Greg, welcome to the show.
Thanks, Ross. Happy to be here.
So I think when we think about frostbite, it can be a somewhat challenging topic to conceptualize in your brain because there's way more than meets the eye on just your physical exam with regards to how extensive the injury is and the types of morbidity that might occur from the injury down the line. It's also, I think, a little nerve-wracking for providers because we don't always necessarily know how much or how little to do in the field. It is winter here now, as February, as we're recording this episode, although it doesn't feel terribly like winter in the Rockies. However, it is crazy cold on the East Coast. And I just got back from NAMSP in Tampa, Florida, where it even reached 32 degrees there as well. So I'm excited to jump into this seasonal topic with you. And so first and foremost, talk to me about the importance of understanding frostbite from the pre-hospital perspective.
Yeah, I think, frostbite from the pre-hospital's perspective, there's often not a ton to do for these patients that you have to actively do. This is more a situation where doing nothing sometimes can be better, but there's a lot of opportunity to do harm with these patients. So I think it's really important to know what you shouldn't do, in addition to the few things that you can do to help make a difference in the pre-hospital setting, because the morbidity from this can be significant. I mean, frostbite generally affects hands, feet, fingers, toes, and losing something like your dominant thumb can be a life-changing injury.
I think that's a great example as to how just because you know more doesn't mean you should do more. But knowing more is still good because we can understand when we should do less and why it's important to do less.
Absolutely.
Great. So how do you think about frostbite as an emergency physician and a wilderness medicine physician?
I think about frostbite similar to a stroke, actually. The damage is not primarily from tissue freezing. The damage is from underlying microvascular damage. And you ultimately do get microvascular thrombi and leading to ischemia and profound inflammatory cascade in the affected digits or limb. The big difference that I think is really important to keep in mind if you're going to think about this like a stroke is think about this almost as if someone has had a stroke and they don't have a skull to protect their brain. So if you had someone who had a large right-sided stroke and had a prior right craniectomy, you would not want to put any pressure. You'd want to guard that side of the skull or the brain really, really well. Same with frostbite. You basically have a stroke of the hands if you have frostbite of the hands, and you have the opportunity to damage that further by even minor trauma to the hands that you can accidentally cause and transport can be a big problem down the road.
Fascinating. So essentially these digits or body parts are becoming ischemic due to the disruption in blood flow from all of those pro-inflammatory cascade that occurs that you're saying.
Correct. And the problem doesn't really show up until you warm the digits. Remember, cold tissue does really well without a lot of blood flow, but as soon as you warm that digit, the clock sort of starts, and that's when that pro-inflammatory cascade and the tissue damage really can start to occur.
I want to interject a question, I guess, mainly about the presentation. So, I think in pre-hospital education, whether it's EMT, woofer, paramedic level training, we get taught frequently how painful frostbite can be. But talk to us a little bit about the initial phases of frostbite when that digit, limb, extremity, whatever is first frozen or affected. How painful is that initial process?
Yeah, good question. So in the stages leading up to frostbite, what's sometimes referred to as frost nip, you essentially have some paresthesias, you'll have loss of sensation of the digits, and it won't be painful at all. It'll just feel like your hand is numb and cold. However, once you start to rewarm that digit, at least with with all degrees of frostbite, you're going to get some amount of severe pain, depending on the depth of the frostbite and how much that involves the sensory tissues. You can either have very, very severe pain or a little bit more mild than you would expect, but expect these patients to have a significant amount of pain upon rewarming, but essentially be insensate before rewarming.
Yeah, I think that's a huge distinction to draw for people encountering these patients in those initial phases. Is it's not going to be painful right away. It's going to feel like they can't feel it. And so there's actually like it takes a pretty heads up person to be sometimes suspicious of this, especially when folks are wearing a lot of clothing, boots and socks and that sort of thing, especially if you're in maybe like an expedition setting, listening to the people within your party and understanding what they're going through. And then also if you're caring for somebody in an urban context, maybe somebody that's living on the street, like recognizing their lack of warmth, maybe where they live, or maybe their shoes and socks are soaking wet and they've been walking around like that in freezing temperatures. Being really heads up to that, I think, is the first step to recognizing it.
Yeah, I think this is part of what's so challenging about it, right? Is like when you think about your normal physical exam findings for things when something's wrong, right? You have pain and you have like abnormal physical exam findings. And you're telling me that you're not going to have pain. In fact, it's going to be insensate. And your physical exam findings may not correlate with the extent of injury until you rewarm them. So as we're going to talk about what you do look for in your physical exam findings in these patients more in this episode, but as we start to dive into the main points of this, can you just lay out what are our main principles that we want to keep in mind as we run through this episode?
Yeah. So first things first is patients who have frostbite they have a really high rate of comorbid, either hypothermia or trauma. Generally, there's some reason that they couldn't move, couldn't get themselves to shelter as the human brain naturally wants to do. And so ABCs are always going to be first. Even if you have someone who you're pretty darn sure has severe frostbite, I mean, they have pallor and insensate fingers up past the metacarpal phalangeal joints. If they're hypothermics, particularly with severe hypothermia, you want to just completely ignore that frostbite. You want to focus on your ABCs as well as core temperature with hypothermia.
That's a great point. When we think about what gets frostbitten, what are the most common things where we see this type of pathology present itself?
Fingers and toes, ears and nose as well. But, ears and nose, there's not great ways to rewarm them as we have for digits and extremities. And they're generally fairly easy to rewarm, and the morbidity from losing a small portion of your ear is probably significantly less than losing a finger. So it's almost always going to be fingers, toes, ears, nose, potentially lips and cheek. But the thing that I think you should focus on the most is the extremities.
And you mentioned our physical exam findings. So what are we looking for on physical exam that's going to suggest something's been frostbitten?
Yeah, so when you have frostbite that hasn't been rewarmed yet, you're going to see pallor. The digits, we'll take the hand, for instance. The digits will be pale, generally not a very sharp demarcation, but can be. And then they'll feel frozen and hard, kind of waxy, and they will not have sensation to those digits. So it actually looks a lot like bad Raynaud's phenomena. And actually the pathophysiology is somewhat similar. So if you can remember that, then have a high index of suspicion for frostbite when you see someone that you think, oh, maybe they have Raynaud's phenomenon. If they have a good story that fits frostbite, you need to consider frostbite.
A good portion of these patients are going to be encountered in the wilderness setting. So say you're on a rescue in the wilderness setting with a patient. Do you want to do like a physical exam there, assess for frostbite, or what do you want to do with their gloves and boots?
It's a good question. So the general teaching is that you really should not walk on or use a frostbitten extremity. The big caveat to that is that if you have someone who needs to walk in order to get to safety, they're at high risk of developing hypothermia, or maybe you are concerned about potential hemorrhagic process going on internally, they might have to walk on that extremity. So in that case, it's best not to remove boots. Now, gloves, if they're loosely fitting, you can potentially pull those off if you're not at risk of refreezing this injury. But as soon as you remove boots and start to rewarm feet, for instance, the swelling is going to be quite severe. You might not be able to get those boots back on. And now you're stuck in the wilderness with someone who has boots off, frostbitten toes, and no way to get them out. So sometimes you do need to leave boots on. I think it's okay to briefly take gloves off as long as you're not in really severe conditions with a low wind chill. But your physical exam in the field, if you know you need to get this person out, I think that you can nearly skip the physical exam, to be totally honest. If they have other reasons that they need to leave the wilderness, you can assess for frostbite later. If they really don't have another reason to leave the wilderness, another reason to call for a rescue, you may need to do a bit more of a physical exam, because if they have frostbite, that is a reason to get them out of there sooner.
Fair enough. And this is in contrast too, right? Like if you're in the urban setting and your ambulance is 5 feet from you, then you're worried less about this.
Correct. Absolutely. Another really important thing to note is that we know, so there's not a lot of great data on frostbite. Honestly, it's a lot of expert opinion, case series or case reports, a couple randomized control trials, but we know all the way back from when Napoleon was retreating from Russia in the War of 1812 that freeze-thaw cycles significantly increase the risk of amputation. So interestingly, this was actually discovered where Napoleon was retreating from Russia, terrible weather, very cold, lots of snow. And his doctors basically observed that the people who were higher up in the ranks and were closer to the fires each night and rewarming their hands and feet by the fire and then going back out and freezing the next day, they had higher rates of amputation than soldiers who were low down on the totem pole and way in the back of the cohort not getting to warm themselves each day.
Interesting.
Yeah. So freeze-thaw cycles, repeated freezing and thawing is really bad. So if there's any chance whatsoever that this limb could freeze again, you do not want to rewarm that.
So with that in mind, trying to avoid this, freeze thaw cycle, like how do you approach this patient? Again, say you're in the wilderness setting and say maybe my most recent frostbite case was a phone call that I got from EMS. They're on standby and search and rescue is attempting to reach an individual who was in a cabin, had been trapped outside all night, was found by some people, headed to a backcountry hut. He was actually not too far from the backcountry hut, so they brought him into the backcountry hut. He still has to get out of that wilderness setting, but now they're in a hut with a fireplace. How do you approach that situation?
As far as what to do next?
Yeah. You just brought him into the hut. He's cold. Do you warm him up, realizing that you still now have to extricate him from the scene, or what do you do?
Sure. So, first thing's definitely going to be ABCs. In that instance, there's a high likelihood that this patient has hypothermia, at least to some degree. Now, if they have very mild hypothermia, they're not altered at all, you can more or less, put that on the back burner. You do need to warm them up, but you can look for other injuries and look for frostbite at that time. Now, let's take the patient let's say that patient did not have hypothermia. They were awake, alert, oriented. Even if you don't have a core temperature, you know that if they have hypothermia, it's not going to be super severe, putting them at increased risk of cardiac arrest. The question then comes to, how quickly can we get this patient out? How are they going to get out? And is there risk of refreezing on the way out? So if you knew you had a helicopter that was coming and they were going to be there in 20 minutes, what we'd actually recommend is not doing rewarming unless they had a really rock solid plan to rewarm. And we'll talk a little bit about how to rewarm later in the podcast. And you wouldn't keep the digits cold or the extremities cold, but actually the recommendations are just have the patient put them, against bare skin on abdomen or axilla or groin. You can start some passive rewarming that way. But if they're within 2 hours of reaching definitive care in an emergency department or some other, clinic that has capability of warming the proper way, then you don't want to start active rewarming with a water bath in the field. Now, if, for instance, that patient was snowed in a blizzard, there was no way that they were going to get to definitive care within 2 hours. Let's make it really easy and say the snow is not going to let up for 12 hours. Then the question becomes, okay, well, how are we going to get them out of here? And do they have a risk of refreezing? If we're pretty darn confident, we've got a lot of search and rescue people there. We know we can keep this patient warm. We're confident that we can keep those extremities from freezing again. You may actually consider warming that patient up in the field with a hot water bath between 37 and 39 degrees centigrade.
So say we have like an in-between. You're up at this hut. Search and rescue is probably not going to get to you for a couple hours, and then they're going to have to get them out. I mean, do you, in that situation, you can't just leave them outside. In that situation, do you bring them in the hut? Maybe not do active rewarming with a bath, but start the fire and have them do that kind of passive rewarming until search and rescue gets there?
Yeah, I think that's pretty reasonable if you're very confident that search and rescue is going to be able to keep the hands from refreezing, which they should be able to do. I mean, something as simple as a Nalgene full of hot water on the transport out should keep those extremities warm. So I think it's reasonable you definitely should bring that patient in either way. I mean, there's no reason to keep them out in the cold. And if you don't have the capability to actively rewarm with a hot water bath, still the recommendation would be just to do passive rewarming against, the patient's skin. Some recommendations actually say if they're a climber, for instance, they can put their frostbitten extremity in their axilla or their patient's axilla or groin. So, yeah, I recommend abdomen over groin. I'm not sure where the groin recommendation came from, but I do think it's reasonable to start rewarming that patient with the means that you have. Now, the big caveat to that is it would be really easy to say, oh, there's a hot fire right there. Let's put his hands next to the hot fire. You really don't want to do rewarming by forced air, hot fire, really anything other than skin to skin contact or a hot water bath would be the recommendations.
Okay. So start a fire and then have him sit in the other corner of the hut.
Yeah.
So long as he's not hypothermic.
Exactly. In wilderness medicine, when we start fires, that is almost always for the rescuers. Rarely is that for the patient. Yeah.
I think this is a very practical example though, because, someone has an insult, they're out in the cold environment, they have a frostbite injury, and then it's human nature, like, hey, while we're waiting for rescue, let's go in this hut where we can be warm. I think that's very, very normal reaction to that situation. And so essentially you're saying being in a warm environment is good enough for passive rewarming. I think some people would tend to want to take a more active role than that. And I know it gets into some of those timeframes you discussed.
Yeah, if we do have an extended time frame and we are going to do some active rewarming, say we have a fire, there's a kettle that you can heat that water. Talk to me how you might do that.
Yeah, so the best way to do this is actually with continuously circulating hot water between 37 and 39 degrees centigrade. Now, in the wilderness setting, that's not always very possible. And so if you have a kettle that you can put on the fire and you can warm up, that's fine. What I would recommend doing is actually getting 2 kettles going if you have them. And then the question becomes, well, how do I know if it's at the right temperature? And what we recommend for that actually is the rescuer. So if you're caring for this patient, you would put your uninjured hand in the water for about 30 seconds. And it should feel warm, it should feel hot, but it should be very tolerable for about 30 seconds. That's when you know you're at about the right temperature. And then you can submerge that patient's hand or foot, whatever is frostbitten, into that kettle. Now, keep in mind that kettle is going to lose temperature pretty quickly. And so that's why you have 2. You want to rotate them out. You really don't want these sort of like picket fence, warm, cool, warm, cool. You want to just continuously warm that hand for about 30 minutes.
This is one of the logistical challenges that struck me when I was first learning about this is, I think about what I take with me backpacking, which is a pot that a hand would barely fit in. And then, just this idea that their hand is like an ice cube. So as soon as when I put an ice cube in my drinking water, it cools off. So if I put their hand in my warm water, it's going to cool off. And so I'm not disparaging this technique. I think what I'm trying to do is impress upon people like the amount of labor this takes is pretty significant and you have to be very attentive to it. And so this is a very involved process.
Absolutely. And another thing to note, you bring up a good point with the pot that you carry, in the wilderness that's small, barely big enough to fit a hand in, is you really don't want any portion of that patient's skin touching the sides of the pot because the risk of burn is so significant. They have an insensate hand that is soon to progress to severe pain. They may not be able to feel if the side of their hand is touching that pot, and frostbitten or very cold tissue tends to burn significantly easier. So you want to just keep that in mind, and really it is a labor-intensive process to rewarm, and you need to be there watching the patient continuously to make sure that they're doing everything they need to be, not, taking their hand out and sticking it by the fire or putting it against the side of the pot.
You bring up a really good point about the pain that's going to start to occur as you thaw this. So let's say you're a rescuer who's been able to make it to the patient. You do have some medications, some supplies, but you're waiting for more hands to help get the patient out. And so you're starting to do some of this process. How would you treat that patient as you're rewarming them?
Yeah, great question. So as far as pain medications, they may need the kitchen sink. This is extremely painful when they're rewarmed. So let's take the patient who's not hypothermic, because remember, we don't want to be giving really any medications if we can avoid it to someone who has severe hypothermia. So let's take the patient who has maybe mild or no hypothermia. They do have frostbite. We're actively rewarming them because we have a prolonged field time on this patient. The first thing you want to give them is an NSAID of some sort. Now, the guidelines sort of go back and forth about which NSAID is best. It used to be aspirin at 325 orally. From animal models that I think were done on rabbit ears, there may be some theoretical benefit to actually using ibuprofen over aspirin. That dose would be 400 milligrams orally. There's not a lot of other data on other NSAIDs, but Toradol is probably reasonable too. And then acetaminophen, I would definitely recommend acetaminophen if there's no contraindications. You can give a gram orally if they haven't had any. And then really opiates. They're going to need opiate medications almost certainly as you rewarm them.
Would you just choose one NSAID, or say you have both aspirin and ibuprofen? Would you give both?
It's a great question. The recommendations are to give one or the other. And currently, based mostly on theoretical reasons, the recommendation is for ibuprofen. So I would stick to one NSAID for now. Now, if you're doing prolonged field care and they're with you for 6 or 12 hours, you can give a second dose, or potentially if you started with Toradol and your medical director says, actually, I want you to do ibuprofen, that's totally fine to switch.
I imagine part of this is to help curb some of that pro-inflammatory response that's occurring. So would you recommend the urban paramedic, if they have an NSAID on the ambulance, administer that at the point of contact before they arrive in the ED, like 10 minutes later?
Yeah, absolutely. It definitely does help with the pro-inflammatory cascade that's going to occur when you rewarm them. But remember, these patients are going to need a lot of analgesia. And so we really want to do good multimodal analgesia for them as well. So I think it's very reasonable to administer 400 milligrams of ibuprofen orally if they can tolerate oral medications, and that will not affect the later on treatment plans that we will administer once they make it to the emergency department or a higher level of care.
Greg, will you touch on so while we're here talking about the sort of this in between, like the part is frozen and now we're considering rewarming and what's going to come next, but talk to me a little bit about maybe what's happening on almost a cellular level. Like there's water content in our cells. So like, I assume that's freezing, and then what's happening, and maybe how do we gauge that, and why is it so painful?
As far as the pathophysiology of what's occurring when you have frozen tissue that you're then warming, with frostbite, remember, it's really the damage to the vascular structures, the microvascular circulation, that ultimately causes the morbidity. You do get ice crystal formation, both intracellularly and extracellularly, depending on how quickly that tissue is frozen. Really rapid freezing, like touching dry ice, is more likely to form intracellular ice crystals. More slow, gradual freezing forms extracellular ice crystals. That's all very interesting. I don't think it has a ton of clinical relevance. What we do know is that in the initial rewarming phases, you get return of blood flow to that microcirculation. That's then followed by often some vasospasm and sort of intermittent microthrombi with multiple episodes of return of normal circulation or near normal circulation. And that's in the immediate rewarming phase. Now, ultimately, with severe frostbite, the microvasculature is going to be damaged. Interestingly, from animal studies, we know that if you take healthy tissue and you graft that onto unhealthy underlying microvasculature that's been damaged by cold injury, that tissue doesn't survive. But if you take frostbitten tissue and you graft that onto an area of the body that has normal microvasculature, that survives. So that really points strongly towards this being a problem with the blood vessels, which is why our treatments are largely focused, at least our in-hospital treatments are largely focused on replenishing blood supply to those digits or that extremity.
That's fascinating. So kind of venous stasis is sort of maybe the confounding insult that's happening.
Yeah, exactly. And just like in a stroke, you get this big pro-inflammatory cascade afterwards. So some of the newer stroke treatments are looking at sort of, suppressing that inflammatory cascade. And some of our treatments for frostbite do the same thing.
It's fascinating. And I definitely want to get back to that as we talk about the in-hospital treatment of frostbite. But back to our patient out in the field, you mentioned one of the most important things is protecting that tissue from damage, from handling that tissue and damaging the tissue when you handle it. So talk to me about the best ways to protect a frostbitten hand or foot.
Yeah, so let's just get this out of the way from the start, because it's still a common misconception that you should rub these tissues. Actually, when I was in Nepal teaching some Sherpas a couple of years ago, that was the common belief, even among Sherpas who work on Everest, is that you should rub frostbitten tissue. So do not rub frostbitten tissue. The best thing to do for that tissue really is to just pat it and protect it. So I would not put you'll see recommendations for aloe vera, that's after warming. I would not put any type of ointment, lotion, nothing on that, just clean, sterile, dry dressings. And you want to kind of separate the digits too. So when you're wrapping them, you really don't want to wrap the digits all together. You want to separate them out. Big, bulky dressings that are easy to get off once the patient lands in the definitive care setting, because we don't want to do more trauma trying to unwrap a really beautifully wrapped hand. You just need a loose dressing to, more so than anything, remind them that they need to be gentle with their hands, and everyone else does too.
Loose, bulky dressing. And that goes for the foot as well?
Exactly. Now, the foot, again, like we talked about, the question sometimes is, should you take a boot off or not? Now, if you think this patient may have to walk out to save their life, then I would leave that boot on, because remember, as soon as you take that boot off, it may be hard to get back on. It probably causes some trauma taking it on and off. And certainly once you rewarm it, you may not be able to get the footwear back on.
Fair enough. Do you see when we think about like burns and skin conditions, you often see some like blistering with a burn. Do you see any blistering with frostbite?
Absolutely. Not with grade 1 frostbite, and we can talk a little bit about grades later, but you're often not going to know in the field. Now, so the blistering only happens once you rewarm the tissue, right? Now, there's some debate about what to do with blisters. Generally in the field, you're going to just leave them. Now, if you have a really tense blister that's potentially over a joint, or you think is imminent for rupture, there's some recommendations to say that you could aspirate that to take a little bit of pressure off. Generally, we don't want to de-roof blisters. And with hemorrhagic blisters, that is a sign of deeper tissue involvement. You want to just leave those alone. Unless you have a vascular surgeon on the phone telling you otherwise, don't do anything with hemorrhagic blisters. But generally for the field, unless you're providing prolonged field care, you just kind of want to ignore blisters and make sure that they're padded.
You briefly mentioned the grading. Is it worth it all thinking about the grading in the field, or is this really something that's just going to be done after they're rewarmed?
I think if you're rewarming them in the field, it's definitely worth thinking about it. So there's a number of different grading schemes. The best one, I think, the most commonly accepted is probably the Cauchy, and I may be saying that wrong, scale, that has to do with how far up the digit the cyanosis extends after rewarming, immediately after rewarming. Now, the in-hospital treatment depends a little bit on that initial grading scale that's graded after you rewarm. And so if you are rewarming, it is important to know a little bit about the grades of frostbite, because that can route you to, say, a higher level of care medical center, or maybe they're okay for your small community shop. Before rewarming, it's really not very easy to grade frostbite at all. Now, you can start to get an idea just based on how far the pallor and the changes that you see in the digits go up the digits into the hand. And if you had someone who's complete, their hand was completely white, insensate, firm to the touch, you're concerned that they have frostbite all the way past their metacarpophalangeal joints. Now, that's probably good enough for you to say, all right, we need to start working towards getting this patient to, a tertiary care center, someone who has multi-specialty, multiple disciplines that can help take care of this patient.
Okay, so let's say we rewarm the patient in the field. What are we looking on our exam after they're rewarmed to grade them, and which grade is going to tell us they need to go to a specialty burn center versus the local center?
Yeah, good question. And I don't know if we've mentioned this or not yet, but before you rewarm, you got to get all the constrictive stuff off that hand. So rings, wrist watches, anything that's on the fingers or hands, do not rewarm them until you've gotten those things off. Because if you rewarm a frostbitten hand that has 5 rings on, you're probably not going to get those off very easy afterwards. So
with regards to that, if you have access to a ring cutter, do you feel like that's the best way to take those off when they're frozen?
It probably is. Yeah. I don't have a lot of experience cutting off frozen rings.
Yeah.
But if you have access to a ring cutter, that's great. The most important thing is just do not rewarm that digit until you get that ring off one way or another. Yeah. As far as once we rewarm what we're looking for, now it can be really helpful for the inpatient team to have a photo of what the extremity looked like before rewarming and immediately after. Before, not as important, but it can be helpful. After, super important. Basically, what you're looking for is as soon as you rewarm, on your end point of rewarming, it generally takes about 30 minutes in a water bath, but your end point is when the tissue becomes red, soft again. Sometimes they can have not quite cyanotic, but sort of a violaceous hue to it. And you really want to look to see how far up the digit that cyanosis goes. So if you have cyanosis just distal to the distal interphalangeal joint, so just affecting the distal phalanx, that's pretty mild. They're generally not going to get some of the more advanced care that we would offer in the hospital, with the exception potentially being the thumbs, because those are pretty important. Now, that would be grade 2. Grade 1 would be no cyanosis. Grade 2 would be cyanosis just on the distal phalanx. Grade 3 is cyanosis anywhere proximal to the distal phalanx, but distal to the metacarpal phalangeal joint. So distal to your knuckles, but involves more than just the distal phalanx, just the tip of the finger. Now, those patients have a higher risk of amputation. Those are the patients that I would say, okay, we need to get them out quick. Just like a stroke, time is tissue. The clock has started as soon as you start to rewarm this patient, and they need to go to a tertiary care center or at least somewhere that has capability to administer some of the medical treatments that we would administer that actually help decrease the risk of amputation. The grade 4 is actually any cyanosis that progresses up past the knuckle joints, so the metacarpal phalangeal joints, or similarly on the toes, the metatarsophalangeal joints. Those have nearly 100% risk of amputation.
So one of those medication therapies that you alluded to, and we'll get into some of the more specialized ones, but one is thrombolytics, so either TPA or TNK. Most local hospitals will have that. Is there a time period by which you should say, hey, if you can get to a burn specialty center, which may have more advanced treatments within a certain time window by bypassing your local hospital, like what would that time window be would you look at, or versus I just need to go get some thrombolytics?
Yeah, good question. So fortunately for some of the newer treatments like iloprost, the vasodilator, that can actually be initiated 48, sometimes even up to 72 hours after rewarming. But the window for either TPA or TNK, the fibrinolytic therapies, that's going to be generally within 24 hours of extrication or rewarming. So I would get your burn center or vascular surgeon on the phone, or whoever manages this locally, and ask them. So I would not just blindly give them TPA if the vascular surgeon who's going to ultimately manage them is a phone call away. I would ask them, hey, do you want me to give them fibrinolytic therapy? They've been out of the wilderness for X number of hours. I think I can get them to you in X number of hours. Do you want me to give them fibrinolytic therapy, or do you want me to hold off and you can do either intra-arterial fibrinolytic therapy or iloprost?
So are you, is it kind of one or the other here too, either thrombolytics or iloprost?
Not necessarily one or the other, but generally one or the other. So there has been one open label trial comparing iloprost and fibrinolytic therapy to fibrinolytic therapy alone. I think they had a third arm as well. And interestingly, this is a small study, high risk of bias. Again, we don't have great data on this, but the amputation rate was interestingly higher in the fibrinolytic and iloprost group than it was in the iloprost alone group.
I have a question for both of you, I guess, thinking about this from the perspective of a flight provider. And you both work in the context of a community or regional center. If the patient, like we're describing from the backcountry trip that was in the hut, they get brought to your facility, is your first thought, okay, how can I get them? What's the time frame by which I can get them to tertiary care, and then that dictates whether you initiate rewarming, or are you guys just going to initiate rewarming and then let the other pieces fall into place?
It's a good question. That patient is going to get rewarmed regardless. Once they're in higher level of care where we can properly rewarm them with a water bath and we know there's no risk of refreezing, we're going to rewarm them right away. Leaving an extremity cold for prolonged periods of time just risks further damage. Now, you do need to know that as soon as you start to rewarm them, that does start the clock, right? Just like with the stroke, time is tissue. And so you need to be aware of that. As soon as you start to rewarm, that's when the damage really starts. However, you're not going to delay rewarming thinking that you can just, hit snooze on the alarm button and buy some more time.
Got it. Yeah.
And that goes for the field too, right? If there's no risk for them refreezing in the field, you can start at least some passive rewarming as you transport to the hospital.
Correct. Yes. Yep.
And let's say you've rewarmed them in the field. Let's say you were stuck in the backcountry. You decided to do a backcountry water bath before rescuers got there. How do you protect that thawed tissue as you extricate them? Is it similar to the frozen tissue or different?
Yeah, it's a little bit different, but not significantly. So we still want to put bulky, sterile, dry dressings on. The only caveat is that if you have topical aloe vera gel available, you can slather that kind of all over. The thinking behind that is that, aloe vera has some anti-inflammatory properties. With frostbite, you want to fight the inflammatory cascade every way that you can, essentially. And so you can slather them with some aloe vera before you put those dressings on. Now, the one kind of caveat I'll make to that is if someone's going to rapidly be in definitive care and we're going to have to wash off all of whatever you put on there, you may just say, okay, let's just wrap them in dry, bulky dressings instead to minimize the risk of further trauma when we get them in the hospital and have to clean off whatever gunk you put on there. But if they're gonna have a prolonged transport time, it's very reasonable to apply some aloe vera there.
When we talk about hypothermia, we talk a lot about the decrease in metabolism and how the fact that you can have like very remarkable outcomes with prolonged CPR and stuff like that. Does that metabolism rate play a role at all with these, or is that really just kind of outweighed by that inflammatory response that damages the microvasculature?
Yeah, it's an interesting question. I don't know that there's a ton of data to address that, but it probably is protective to some degree. I mean, you can have completely frozen solid tissue, and if you can salvage the vasculature beneath that tissue is viable still. Yeah.
So then that plays a little bit into the medications we give in the emergency department to try to salvage that, or in the hospital. So with salvaging that microvasculature, that gets into a little bit of the treatments we do in the hospital with regards to the medications we already alluded to. But before we start talking about the in-hospital treatment, is there any other things we need to address or treat while we're out in the field?
So one other thing to note, and this sort of goes back to your ABCs too, is that you want to aim for normo everything, similar to a stroke. So you want them euvolemic. So if they're hypovolemic, if they're dehydrated, which can happen from hypothermia, you want to get some IV fluids in them, and you ideally want to do that with warm, small boluses of IV fluids. Now, keep in mind, if you're running that through 15 feet of tubing to get to the patient and you're out in the wilderness setting, that's going to get cold. So you don't want to make this patient colder if they're at risk for hypothermia. The other thing to note is that much like a stroke, you want them normoxic. If they are hypoxemic below 90%, then you can administer some supplemental oxygen. If they're up above about 13,000 feet or 4,000 meters, then you can also just go ahead and give them a little bit of supplemental oxygen via nasal cannula.
Yeah, one other question that that keeps coming to my mind before we dig into the in-hospital treatment of these patients is we're talking pretty specifically about isolated frostbite, but are there any pearls of wisdom you have about what if there's a traumatic injury as well with these extremities?
That actually becomes pretty easy if they have a traumatic, especially a life-threatening injury. You just ignore the frostbite. So, and same thing with hypothermia, you just ignore the frostbite if they're severely hypothermic. Actually, treating your frostbite in a severely hypothermic patient can put them at high risk of cardiovascular collapse. Because remember, with hypothermia, severe hypothermia, we don't want to warm the extremities. That'll cause massive peripheral vasodilation in a patient who's already probably volume down and can lead to cardiovascular collapse. So, severe frostbite, severe trauma, just completely ignore the frostbite.
I love that. And I think that's a really important principle to drive home as we think about these complex, challenging patients who have multiple things going on and maybe an austere environment, is you can start to feel very cognitively overloaded with where am I? How do I get out of here? They have all these things going on. So I think it's really important to reinforce and understand that, like, ignore the frostbite until you've addressed the life threats. Like, on your priority list, that falls to the bottom until you've addressed those things. And then you can start devoting some cognitive energy to that.
Yeah, absolutely.
Okay, so I want to go one step further and help our EMS clinicians understand what we're going to do for these patients once they arrive in the emergency department and then as they're treated in the hospital. But before we go into that one step further, can you just bring this home for us and give us the take-home principles? If you remember nothing else on your next shift on Monday, what do you need to remember to take care of these patients?
Yeah, so ABCs first, treat hypothermia if it's severe, treat trauma, ignore the frostbite if they have other life threats. I would say that's first and foremost. The second is, you really want to do no harm. And so handling these patients gently, don't allow them to ambulate on frostbitten extremities, don't allow them to go through freeze-thaw cycles.
Perfect. So the patients in the emergency department, what are we going to do? Say we need to, they're still frozen. We need to rewarm them. How are we going to logistically do that in our emergency department? And then what's our next steps from there?
Yeah, great question. So many emergency departments will probably just be using water baths where they, heat up some water or just get it out of the sink warm. They'll test it if they don't have a thermometer, although you want to ideally get it to 37 to 39 degrees centigrade. You can test that easier with a thermometer in the hospital. You can put a little bit of povidone iodine in there or chlorhexidine just to keep it a bit more sterile. There's not great evidence for that. And then you want to rewarm in that water bath. So an easy way to do this is 2 emesis basins, one sort of being tended to by a team that's getting it to the correct temperature, the other to rewarm the frostbitten limb. A more elegant way to do it that there's some data emerging for, and frankly, even without strong data, I think it's very reasonable to try, is a cooking device called a sous vide, which is essentially, it's almost as if it was designed for frostbite. This is a tank that you put a small heater that has a circulating device to keep the water moving. You just put it in a plastic tank, and then there's a thermometer that you just set it to. And so that's just the perfect device for frostbite. They cost somewhere between $50 and $200. I take no money from Big Sous Vide, but I think it's worth considering having one of those in your facility if you practice in a place that has a lot of frostbite.
And as you're doing this, you're going to need to start addressing the pain. So what's your approach to pain management for these patients in the emergency department?
Yeah, if they haven't already gotten an NSAID, they're going to get an NSAID from me. They're going to get a gram of Tylenol. And then there's some evidence to show that maybe you can do some nerve blocks on these patients. But as you can imagine, doing a nerve block while someone is, trying to reheat their hands in a water bath may be technically difficult. And so I'm really going to go with IV opioids.
Okay. What about ketamine?
Ketamine's probably reasonable. I haven't seen a lot of data on it, but pain dose ketamine is probably very reasonable. It's interesting. I wonder if there's any degree of clinically significant peripheral vasoconstriction with it. It's probably not unreasonable, but the safer bet is opioids. Okay.
And you talked a little bit about fluid status in the pre-hospital setting. How are you addressing their fluid status, either addressing what their fluid status is and then treating it in the emergency department?
Yeah, so if they're trauma and I think they need blood, then they're going to get blood. But if not, if they're, let's say they had some mild hypothermia, they maybe had some cold diuresis, they're a little volume down, I'm just going to give them warm crystalloids. Generally, if someone has more severe hypothermia, we want to avoid LR, lactated ringers, and you would actually go with normal saline in that instance because the cold liver doesn't metabolize LR very well. That's all sort of theoretical stuff. I don't think it matters all that much as long as they're getting some crystalloid if they're volume down, and as long as that crystalloid is not cold.
And as we start to salvage that microvasculature or attempt to in the emergency department, let's say you're, historically, how was this treated up until this last year when we had some new medications, at least in the US, enter the market?
Yeah, so this is interesting. Actually, the US data on this lags quite a bit behind some other places like Europe and the Himalayas, with maybe the exception of Alaska. They tend to see a lot of frostbite up there. Historically, in recent decades, this has been treated with fibrinolytic therapy. So TPA was always the mainstay. Now, a lot of centers are switching over to TNK, and many don't even have TPA anymore. We don't have as robust data for TNK, but it probably works about the same. I mean, that's kind of what we've done with strokes, is say, it probably works about the same as TPA, so we'll use TNK now. So if you only have TNK, that would be, the standard of care now. If you have TPA, there's a little bit more data for it. How you give the fibrinolytic therapy is sort of interesting. You want to involve your specialist. If you don't have a vascular surgeon or someone who deals with frostbite very frequently, probably just systemic IV is the way to go to start. If you do have a vascular surgeon or some other subspecialty team who manages frostbite, there's some data to show that potentially intra-arterial with a fancy catheter that they drop may have a slightly better salvage rate as far as decreasing amputations. Now, that's been the mainstay for quite a while now. That is still a recommended treatment, one of the only ones that probably decreases amputation rate. But there's it's not really new, but there's a medication that was newly FDA approved, has been used in Europe and the Himalayas for a while, called iloprost.
And before we get there, just to confirm with TPA, whether it's systemic or intra-arterial, the timeline window for that is 24 hours from rewarming?
Correct, yes. Now, if a vascular surgeon were to tell me, this patient has terrible grade 4 frostbite and they're a concert pianist and they're 36 hours out, I want you to give fibrinolytic therapy, that's fine. I would just talk to the patient and make sure they know that there's potentially a bit of an increased risk. All the normal contraindications to your fibrinolytic therapy still stand. There's a couple different relative contraindications, one of which, interestingly, being repeated freeze-thaw cycles, but it's not an absolute contraindication.
Okay. And so you've mentioned iloprost. So this same patient that I was discussing earlier that I got a phone call by EMS on standby for, I actually then shortly after that got a phone call from a wilderness medicine doc based out of Seattle, who apparently had some connections with the owners of these backcountry huts and had been notified about this patient in their hut system and had reached out to her for some guidance and advice. Being the closest emergency department, I then received a phone call from her, and her biggest concern was trying to help coordinate getting this patient to a center that had iloprost. Iloprost, as you mentioned, is a newly FDA-approved medication here in the U.S., so many centers do not have access to it right now, which is why she was trying to help coordinate that. Tell me why. What's the big interest in iloprost?
Yeah, it's sort of, as far as medications go for frostbite to restore that normal circulation, it's a great medication mechanistically. It's a potent vasodilator. So it's sometimes used in pulmonary artery hypertension, but it's a potent vasodilator, and it also probably has some effects on platelet aggregation, which can decrease the microthrombi. And then it also probably has some anti-inflammatory effects as well. So it sort of attacks, every single element that we're trying to treat when we're trying to give these patients the best risk of keeping their limb or their digit.
Okay. And I guess I should probably clarify, I don't know about this. It may have been FDA approved for other etiologies in the US, or is it only used for frostbite?
Yeah, I think, double check me on this, but I think that there is a inhaled form that's used for PAH, pulmonary artery hypertension, but the IV formulation for frostbite was recently approved. And interestingly, the study that they sort of cite in their approval is not big, but again, in the world of frostbite, we don't have robust data. And so it was good enough for them to say, okay, this probably works pretty darn well, actually. Let's approve this and get this on the market.
Yeah. So probably the most robust data that does exist is for TPA, as that's been studied for quite some time here in the US. Iloprost has been around for a while, and there are some smaller studies, mainly in Europe, but like remarkable results from these smaller studies. And anecdotally, from people you've heard in the wilderness medicine setting who have a lot of experience using this medication, sounds to be much more effective than TPA.
Yeah. It does sound to be much more effective than TPA. Again, data sets are very limited on this right now, but it seems to be safe, pretty well tolerated. It is generally infused over a long period of time, so multiple days of infusions in an ICU because there's risk of hypotension, but seems to be safe, seems to work as well, if not better than TPA or TNK. And so I think this is probably where treatment options are going in the future for severe frostbite.
Yeah, I know there's a lot of interest in it right now. So hopefully we do get some larger data sets that answers this question more definitively. Is this really as remarkable and helpful as we're hoping it to be?
Another important addition, that this is something that you need to chat with the team that's going to be managing this patient to see what they want exactly. But once TPA or TNK is given, if given systemically IV, you do need to start them on some sort of anticoagulation, the mainstays being either unfractionated heparin or enoxaparin.
So see, I think we're, in the interfacility world, we're very familiar with transporting patients who have gotten TPA or TNK for a stroke. So we understand the risks, we understand what we're kind of looking out for in those patients, which you said is very similar when we're using it systemically for frostbite. Iloprost, you sort of mentioned its side effects. Say there's a non-burn center who has access to Iloprost, has given it, and now you're being asked to transport this patient to a burn center. What are you looking out for during that transport?
Hypotension is going to be the big one. That's kind of the main thing. And you can slow the infusion down or use all your other normal techniques to raise the blood pressure if needed. But hypotension is the big one. One of the benefits of Iloprost is that it may hold some promise for being administered in the field due to the increased safety profile compared to fibrinolytic therapy, decreased risk of massive hemorrhage, et cetera.
With regards to hypotension, is it preferred to turn it down? Or because when you say you can use vasopressors, one of the things I think about is we now know that vasopressors are generally safe through a peripheral line in a person who does not have frostbite but is critically ill for other reasons and needs vasopressors. Is there concern? The big concern with a peripheral line and using vasopressors has always been, are we going to clamp down the microcirculation in the hands and cause harm? We haven't seen that bore out. Again, these were patients without frostbite. So is there concern with that in a frostbite patient? Should you have a central line if you're using Iloprost to give vasopressors? Would it be preferred to try turning it down first before you use vasopressors?
It's a good question. I would preferentially turn the Iloprost rate down or even stop it. And I think some of the protocols have specific guidance on how to do that and when to restart it and at what rate. I would do that before I started pressors because of the increased peripheral vascular resistance, the clamping down peripherally, which could worsen outcomes potentially, at least theoretically. And then, of course, IV fluids too. Remember, a lot of these patients are hypovolemic, so just make sure that you've got them euvolemic and they can probably take more fluids too, many of them.
Greg, was the usage of Iloprost, was there other medicines that were given empirically like to pioneer this, like other pulmonary hypertension treatment modalities or phosphodiesterase inhibitors, those sorts of things?
Gosh, I think there was. I don't know the names of them off the top of my head. One of the trials, the trial that compared TPA to TPA plus Iloprost, also had a third arm that I believe was another vasodilator. I do not know the name of it, and none of them have ever made it into the recommendations.
And as you've already said,
ones.
the sample sizes are usually low and the data is scant.
Yes, quite small. However, if you talk to people who act as medical directors for some of these rescue associations in the Himalayas, and that's probably where a good majority of this data lies. It's just it hasn't been published or presented or picked apart yet. But if you talk to them, they'll say, oh yeah, this is not new. I mean, we've known this stuff works forever. I can't believe this is just now catching on.
They're giving people Viagra for.
Yeah. No, I mean, I do think they've looked at nifedipine and some other medications, topical nitro. So there certainly was some precedent to start looking at iloprost, but none of those are recommended currently.
Gotcha. Thanks.
Other than iloprost. Yeah. Another paradigm shift in frostbite care is that there used to be a saying, I think it was freeze in January, amputate in July. And that was basically because it takes a lot of time, multiple months, to see where viable tissue is going to start and end before a surgeon will say, okay, we know this tissue is non-viable. We're going to go amputate that. That has sort of been, we've taken a step back from that a little bit because we have these more advanced therapies and we have improved imaging. So either angiography, technetium-99 scans, or MRA. It can really show us the degree to which we are getting good blood flow to the digits again. So some of these intra-arterial TPA protocols will actually do angiography every so often, every few hours, and they'll just look to see, can we see blood flow past the MCP joint? Can we see it past the PIP joint? Can we see it past the DIP joint? And that helps guide those protocols of when to give more TPA and how much to give.
That sort of reminds me of patients that I would see not too infrequently in the metro area, the urban area, where they had frostbite and would show back up to my emergency department months later with black fingers.
Yeah.
What do I do with that?
Call a surgeon.
Well, yeah, that's a good point, Ross, because, I kind of actually want to harp on this for a second, because if you pull up any EMT textbook and go to the frostbite chapter, you're going to see these pictures of black digits, but that's a late changing thing.
Correct. That takes multiple months. So the exam for frostbite really changes before it's thawed to after it's thawed to day 1 through 4. And then if you look 3 months out, I mean, on exam, the extremity fingers or digits are going to look significantly different. Now, you actually can get mummification of the tissues, and I've seen a couple cases of this. And unfortunately, undomiciled gentleman who kind of came and went from many different emergency departments and never really had this taken care of. And I saw him 6 months after his freezing injury. Now, I think the most important things to know is that they do need surgical follow-up for that. In my experience, most surgeons are not going to take them straight to the OR. They will actually try to get them in for outpatient, with the caveat being that if this patient is septic or if they have superinfection, that is an indication for early amputation.
Sure. So the big thing to look out for in these patients is any signs of infection. Otherwise, it's generally a non-emergent case that the surgeon will tell you to have them schedule in clinic, which has been my experience with these patients as well.
Correct. Yep. Now, there is a risk we should mention of compartment syndrome. From my read on the literature, that seems to be fairly infrequent and does not seem to occur in these late stages where you have mummification of digits. That seems to be a somewhat more earlier finding. So it's something to keep in mind, and that would be a reason to take them emergently to the OR.
And so what is that going to essentially present like? Concern for a compartment syndrome post frostbite injury?
Yeah, I think it's going to look a lot like your normal compartment syndrome. However, the caveat being is that some of the tests we do, like pain with passive extension, that's going to be really tough to grade if someone has very severe frostbite to their digits and you're trying to rule out compartment syndrome of, say, the forearm. Generally, they're not going to have frostbite all the way up that far. And if they do, the surgeon's going to be heavily involved anyways. So, but you're going to look for all the normal things that you would see in compartment syndrome. It can just be a tiny bit more diagnostically challenging. And so having your subspecialty consultants on board early can help you sort that out.
And like you said, I imagine this is something that's not likely going to present months after the injury. It's going to have some sort of inciting, like suddenly they developed worsening swelling for some inciting reason. Yeah,
it's probably when it does happen, it's probably more in that acute post-thawing pro-inflammatory response phase in the first, days to hours. One thing that I would just like to reiterate again is that, remember, we're here to treat the life threats, and we're here to, try to improve long-term outcomes, but we're also here to help with pain and symptom control. And so don't be afraid, if these patients are stable, to give them pretty big doses of analgesia medications while you're rewarming them. this is extremely painful. And you really you want to be nice to your patient. They're already having a really bad day. So one other thing to mention, if people want to read more about frostbite and the pre-hospital care setting, probably the gold standards as far as guidelines come from the Wilderness Medicine Society. The state of Alaska also puts out a really great kind of guide to frostbite that I think is used throughout their rural centers. And they actually include full checklist for contraindications to TPA or TNK, and they have protocols for, I believe they have protocols for iloprost as well as thrombolytic therapy.
Nice. We'll include those links in the show notes for you guys to reference if you have interest looking those up. Well, thanks so much for joining us, Greg. This has been super enlightening and hopefully helped clear up some of the challenges we see with these patients.
Yeah. Thanks for having me.
Yeah. Thank you, Greg. This is great.
Yeah. Thank you, Will. And that was basically because it takes a lot of time, multiple months, to see where viable tissue is going to start and end before a surgeon will say, okay, we know this tissue is non-viable. We're going to go amputate that. That has sort of been, we've taken a step back from that a little bit because we have these more advanced therapies and we have improved imaging. So either angiography, technetium-99 scans, or MRA. It can really show us the degree to which we are getting good blood flow to the digits again. So some of these intra-arterial TPA protocols will actually do angiography every so often, every few hours, and they'll just look to see, can we see blood flow past the MCP joint? Can we see it past the PIP joint? Can we see it past the DIP joint? And that helps guide those protocols of when to give more TPA and how much to give.
That sort of reminds me of patients that I would see not too infrequently in the metro area, the urban area, where they had frostbite and would show back up to my emergency department months later with black fingers.
Yeah.
What do I do with that?
Call a surgeon.
Well, yeah, that's a good point, Ross, because, I kind of actually want to harp on this for a second, because if you pull up any EMT textbook and go to the frostbite chapter, you're going to see these pictures of black digits, but that's a late changing thing.
Correct. That takes multiple months. So the exam for frostbite really changes before it's thawed to after it's thawed to day 1 through 4. And then if you look 3 months out, on exam, the extremity fingers or digits are going to look significantly different. Now, you actually can get mummification of the tissues, and I've seen a couple cases of this. And unfortunately, undomiciled gentleman who kind of came and went from many different emergency departments and never really had this taken care of. And I saw him 6 months after his freezing injury. Now, I think the most important things to know is that they do need surgical follow-up for that. In my experience, most surgeons are not going to take them straight to the OR. They will actually try to get them in for outpatient, with the caveat being that if this patient is septic or if they have superinfection, that is an indication for early amputation.
Sure. So the big thing to look out for in these patients is any signs of infection. Otherwise, it's generally a non-emergent case that the surgeon will tell you to have them schedule in clinic, which has been my experience with these patients as well.
Correct. Yep. Now, there is a risk we should mention of compartment syndrome. From my read in the literature, that seems to be fairly infrequent and does not seem to occur in these late stages where you have mummification of digits. That seems to be a somewhat more earlier finding. So it's something to keep in mind, and that would be a reason to take them emergently to the OR.
And so what is that going to essentially present like? Concern for a compartment syndrome post frostbite injury?
Yeah, I think it's going to look a lot like your normal compartment syndrome. However, the caveat being is that some of the tests we do, like pain with passive extension, that's going to be really tough to grade if someone has very severe frostbite to their digits and you're trying to rule out compartment syndrome of, say, the forearm. Generally, they're not going to have frostbite all the way up that far. And if they do, the surgeon's going to be heavily involved anyways. So, but you're going to look for all the normal things that you would see in compartment syndrome. It can just be a tiny bit more diagnostically challenging. And so having your subspecialty consultants on board early can help you sort that out.
And like you said, I imagine this is something that's not likely going to present months after the injury. It's going to have some sort of inciting, like suddenly they developed worsening swelling for some inciting reason.
Yeah, it's probably when it does happen, it's probably more in that acute post-thawing pro-inflammatory response phase in the first, days to hours. One thing that I would just like to reiterate again is that, remember, we're here to treat the life threats, and we're here to, try to improve long-term outcomes, but we're also here to help with pain and symptom control. And so don't be afraid, if these patients are stable, to give them pretty big doses of analgesia medications while you're rewarming them. This is extremely painful. And you really you want to be nice to your patient. They're already having a really bad day. So one other thing to mention, if people want to read more about frostbite and the pre-hospital care setting, probably the gold standards as far as guidelines come from the Wilderness Medicine Society. The state of Alaska also puts out a really great kind of guide to frostbite that I think is used throughout their rural centers. And they actually include full checklist for contraindications to TPA or TNK, and they have protocols for, I believe they have protocols for iloprost as well as thrombolytic therapy.
Nice. We'll include those links in the show notes for you guys to reference if you have interest looking those up. Well, thanks so much for joining us, Greg. This has been super enlightening and hopefully helped clear up some of the challenges we see with these patients.
Yeah. Thanks for having me.
Yeah. Thank you, Greg. This is great.
Yeah. Thank you, Will.